progressing panencephalitis or
and the medications were then tapered off. And then he came back again, and you can see that he's got this KP here. If you look at the distribution, you know, it's more than what we would expect for any kind of PI-related or angle closure-related kind of inflammation. They don't get keratic precipitates, right? So after a while, he seems to quieten down. His pressure is good. But you can see that these KP, they are pigmented. Okay, that's a bit unusual, right? Even if you hit the iris, you shouldn't get all these clumpish, pigmented KP. You may get some pigment liberation, especially if you have done iridoplasty. So 2 months after the initial presentation, he presented with dendritiform corneal lesions, some corneal edema, keratic precipitates, anterior chamber cells were present. So he is treated again by the general ophthalmologist with AIOC acyclovir 5 times a day, and it resolved, it responded well. So they thought, in the case notes was written, query hepatic, all right, HSV kind of keratitis. So the following month, he came back this time. The pressure had gone up again. It was 30. He had cells, and he had keratic precipitates. So at this time, he was referred to the uveitis clinic. That's 6 months after his initial presentation. And of course, what we typically would do is paracentesis of the AC, aqueous, sent it for PCR analysis, and this turned out positive for VZV, okay, varicella zoster, and it was negative for the other viruses. So we treated him orally, and this was then reduced, and we gave him only like 1 month of treatment, and he subsequently resolved. He never had vesicular eruptions. So no one would be able to really diagnose this case if not for PCR analysis of the aqueous. So is this the end of the story? Well, if you have only treated VZV after 6 months of the disease from presentation time, you would expect complications, which 3 months later, now he comes with bilateral fine KPs and cells. Then you begin to wonder, bilateral viral uveitis, a little unusual. Okay, so 1 year later, the same right eye that initially presented developed neuropathic keratopathy. He had all the punctate epithelial erosions you can see here on the cornea. And then he has bilateral high pressures in both eyes, and he has developed fine feathery KPs, like what you see here. And now the left eye, the right eye we tapped again because we were not certain whether it was something else or just a recurrence of the VZV. So we tapped him, and he was negative in the right eye for viruses, but the left eye was positive for CMV. Okay, we never expected it to be CMV because this guy's got VZV in his right eye, and he's actually healthy with no underlying immunocompromise. So we treated this patient with Vergon gel, which is ganciclovir gel. So this patient actually improved for some time, but if you look at what happened thereafter over the next 8 years, all right? So he developed cataract, he had glaucoma, the right eye that needed glaucoma surgery. The left eye, he developed cataract, which is not unexpected for his age, but he needed a trap MMC. And then the right eye, which was neuropathic, had a paracentral melt with secondary infectious keratitis, and then he had to undergo a DELC. The left eye had penetrating keratoplasty because it was delayed diagnosis because of CMV. He had endothelial failure, and then he had vascularized grafts, so twice failed, but he had no recurrence of CMV thereafter when he was appropriately treated. And then at the last that we saw him, he had 6/12 vision. That was the eye that had the VZV, but the left eye was light perception because the cornea was opaque, and then he passed away 2 years after that. So you can see there's a downhill progress when we miss the diagnosis. Okay, so suspect viral etiology in hypertensive anterior uveitis. VZV anterior uveitis can present in the absence of vesicles, and so you really need PCR for analysis. Both eyes can harbor different viruses. You need PCR really to make the diagnosis, to give the appropriate treatment. Eyes with viral anterior uveitis tend to develop relapse, okay? Glaucoma develops over the long term, and so does cataract. CMV eyes undergoing corneal transplantation have a very guided prognosis because you give them topical steroids, and then they will have further relapse and loss of endothelial cells and failure. So missed or delayed diagnosis results in really serious loss of vision for our patients. So how then not to miss a viral anterior uveitis? So when do we suspect a patient to have a viral etiology? So usually these patients present with one eye involvement. They have raised pressure at the time of presentation. Iris atrophy may be present, pigmented, small, medium-sized, or others may have stellate and diffuse KPs. The presence of corneal involvement, either acute or just in the presence of scars, and the early development of cataract in some types of viral uveitis. So the pressure is raised. Are there causes? So if it is low, we think of B27-associated anterior uveitis or retinal detachment, right? But if it's high, we think of an infectious cause. So you can see some viruses here, herpes simplex virus, varicella zoster virus, Fuchs uveitis syndrome, which is associated with rubella, Posner-Schwarzman syndrome, which sometimes on repeated tap may become positive for CMV, toxoplasmosis, infection, syphilis, sarcoidosis can do this. Of course, lens-induced glaucoma can do this too. The other thing is to look at the iris, okay? Do not just dilate. Look at the iris before you dilate. Look for the shape, all right? You may see iridopecia like in this patient here. There may be atrophy or stroma or pigment epithelial layer. Sorry, is someone, okay. And the stromal involvement may be patchy or may be diffuse. So you can see some examples here. If you have a segmental area of involvement, it's typically HSV or VZV. And you can see in this case of recurrence, without appropriate prophylaxis, this patient had severe transformation defects and he suffered from severe glare because this just tended to recur and destroy more of his iris that involved not just the stroma but also the pigment epithelial layer, giving the transformation defect. So if you are dealing with something like CMV, all right, whether it's a chronic CMV or the acute recurrent, which we call Posner-Schwarzman syndrome, they tend to get more stromal involvement and just patchy or diffuse atrophy. So this CMV involvement can look just like a rubella, eye with rubella virus, okay? And VZV tends to be far more severe than HSV in terms of iris atrophy, and they can get even a fixed dilated pupil that transminates after a single episode of severe infection. So CMV and rubella both have very low flare, and they do not develop posterior synechia despite chronicity. So that's a very nice clue for you if they have recurrent inflammation, chronic inflammation, and yet the iris does not get stuck down. And of course, if you do gonioscopy, you may see anthracene positive in both these viruses. How about the KPs? Can you tell whether these KPs are infectious or not? And very nice work has been done initially from James Rosenbaum's group and subsequently other authors, including Padma Malini. And they have shown that infectious and non-infectious KP look different on confocal microscopy, which gives you a very highly magnified view of the KP. And typically, infectious KP look either dendritiform or infiltrating as compared to non-infectious, which look more smooth and globular, and others may be cruciform or stipple. So is there a clinical correlation with this? When we look at the patient clinically, you can see this is dendritiform, and this patient was CMV positive. This was globular, and this was biopsy-proven sarcoidosis. And this, interestingly, infiltrating, you can see, in fact, they've got little streaks there coming out from the KP, and this was vitreoretinal lymphoma. So how about the pattern of the distribution of the keratic state? We've been observing that KP that go above the horizontal meridian point more to an infectious than an immune cause. So for example, HSV, VZV, CMV, which is diffuse, rubella, which is diffuse. So, you know, when we look at Fuchs uveitis, what are the associations with these diffuse dendritiform or infiltrating KPs? They are mostly infectious, right? So rubella has been associated with Fuchs uveitis syndrome, CMV, chikungunya virus, HSV has been reported as well, Ebola virus. So these are mainly infections, as you can see here, except for sarcoidosis. And maybe sarcoidosis may be infectious actually in the origin, in the trigger. So the KP distribution, you can see others here like VZV, they go above the horizontal meridian. This is HSV1, you can see very diffuse involvement. And this is syphilis, it goes right up here. Okay, so look very carefully at the distribution. It may indicate a possible infectious etiology. So you just do note that, you know, when we're talking about the distribution, we're talking about when the patient first presents to your clinic. Of course, the patient is already treated before his patient sent to you. You may actually not see these signs. So this patient here had actually very diffuse type of infiltrative KPs. So when this patient was treated, you can see this was CMV. The KPs start to change and evolve, all right? They become a bit more granulomatous. And at the end, very interestingly, the top ones were granulomatous and the below was still rather dendritiform. So we're talking about when the patient first presents to you, if they are diffuse, they're dendritiform, and so on, these would tell about the possible characteristics and etiology of the underlying trigger. The color is very useful. So pigmented KP, they may help to suggest a viral infection. So my resident asked me today, this week, and she said, you know, I thought pigmented KPs are all KPs. So when we look at these pigmented KPs, they are not small and crenated KPs. All right, they're actually fresh KP that are pigmented, that would suggest a viral etiology as compared to these other etiologies where typically they do not get pigmented. There are some characteristics of the KP that may help you to make a diagnosis. This is CMV with coin-like lesions. This is nodular endothelial lesions that you can even image on ASOCT. And very useful if you're suspecting this could be CMV or perhaps rubella. You know, when you see a Fuchs uveitis syndrome, you do the endothelial cell count, and when you have a significantly reduced endothelial cell count, suspect CMV. All right? If you find scars, all right, you would think more of infectious cause here, right? Think before you even dilate the patient and check the pressure, please check the corneal sensation, because hepatic viruses do cause a decrease in corneal sensation. So of course, non-granulomatous uveitis can also cause corneal lesions, but the keratitis tends to be more peripheral, and you can see some of these here as compared to the viral keratitis that you may see scars or active lesions. The characteristics of rubella uveitis are quite different from the herpes viruses, tend to be in younger patients who present with a white eye, stellate or diffusely distributed non-pigmented KP. You may have heterochromia even at presentation, like this patient of mine. Copy nodules may be present, posterior subcapsular cataract may be present in 50% even at presentation at a young age. Vitritis is almost always present. If you look for it, generally they do not have macular edema even in spite of vitritis. And if you look carefully, some of these patients may even have chororetinal scars. So it's important to confirm the diagnosis because it would impact on your treatment. So aqueous tap is usually done when the eye is active, especially when you have a high pressure, and this gives you a better chance of getting a positive result. So in conclusion, a high index of suspicion is necessary when the patient presents with a high pressure, the KPs that go above the horizontal meridian, pigmented KPs, presence of iris atrophy, corneal manifestations, including a reduced endothelial cell count, and always remember to do a dilated fundus examination to rule out posterior segment involvement. Thank you very much.
Yeah. Any questions for Professor Che?
Okay, so you brought a very good point because people are now looking at the number of nerve fibers and all that, but I don't think there's really anything that's been published from her group on this. But I think Rohit Shetty has been publishing on corneal nerves, and it will be interesting to look at this. Thank you.
Okay. Thanks, Soonpi.